A very good afternoon to everyone. Thank you for taking time out of your busy schedules to attend this live simulation to be performed by a group of our fourth-year medical students. Here we're going to see our students use simulation as one of training methods to teach them how to manage complicated cases in a safe environment. Today, you're going to see a group of our medical students manage a patient who's been involved in a major road traffic accident with serious injuries. And you see them working together as a team and manage this patient who is simulated by this mannequin here. All right, so team is led by Caitlin. Team, are you ready? And this is your scenario. This is a 58-year-old gentleman, Mr. Lee, who is brought into the emergency room by paramedics, complaining of chest pain and shortness of breath after a road traffic accident. The paramedic reports that the patient was riding a motorbike when it skidded and while he tried to swerve away from a lorry that cut into his path. The patient was thrown about 3 meters from the bike. There was no loss of consciousness, and the pillion rider with him has minor abrasions only. A passerby stopped his car and called the ambulance, and Mr. Lee is here in the emergency room, and you're the team here to manage the patient. Please proceed.
Okay, thank you, Prof.
Yeah.
All right, so let's delegate our roles. Before we do that, let's put on some gloves and PPE.
For today, we will assume that you have your gowns on as personal protection, but gloves are important. Yes, please proceed.
Okay, and so now just to assign the roles among all of us, Beth, could you handle the airway as well as take a history from the patient? Junmei, could you manage the breathing as well as take a physical examination? Ying and Nicholas, could you manage circulation? And monitoring, could that be done by Zhiwei? And Karis, could you look at the investigation?
So yeah. Caitlin has assigned roles. Caitlin is a leader, and everyone has been given specific roles to manage Mr. Lee. Please proceed.
Mr. Lee, do you know where you are?
Yeah, I'm in a hospital, doctor.
Okay, what happened to you?
I'm involved in an accident, motorbike skidded.
Okay, where's the pain?
Yeah, on my chest, this lorry came into my path.
Okay, which side of your chest?
The right side, doctor.
Did you lose consciousness?
No.
Okay, do you have any long-term medical conditions?
No, I'm well before. I'm not taking any medication.
Okay, you don't take medication. When was the last time you had a meal?
About 4 hours ago, doctor.
Okay, do you have any drug allergies?
No.
Okay, all right.
So history has been taken. Let's proceed with the...
No secretion.
Okay.
All right, let's check on the physical examination.
Okay, SpO2 currently 91, so...
Okay, SpO2 is 91. Let's start him on some oxygen.
Okay, they noted the oxygen is low, and let's proceed with the primary survey.
Yep, so I noticed that there's some abrasion on the right upper chest, as well as I'm looking for any bilateral chest rise.
Okay, chest rise is equal bilaterally.
Okay, I'm looking for any jugular distension.
No jugular venous distension.
Okay. And I'm feeling for whether there's any tracheal deviation as well.
Trachea central.
Okay. Right now, Mr. Lee, I'll be pressing on the chest a bit. Just let me know if there's any pain.
Yeah, no pain on the left.
Okay. Any pain?
Yeah, pain on the right, doctor.
Okay. Right now, I'll be percussing the chest.
Okay, saturation's improving.
Okay. Equal resonance bilaterally.
Okay.
Okay.
Okay, meanwhile, let's start some fluids for the patient. See, we're starting a normal saline.
Okay.
Thank you.
Okay, IV line has been set up and fluids are being run. How's the breath sounds?
Bilateral equal breath sound.
Okay, breath sounds are equal.
Okay.
Let's proceed with the examination.
Okay, that's reassuring. Meanwhile, have we set up the IV access?
Yep.
Okay.
We taken FPC, renal panel, GXM, PDPTP, as well as arterial blood gas.
Okay, perfect.
So
Thank you.
IVs have been set up and bloods have been sent for lab investigations.
Okay, and now let's do a physical examination of the abdomen.
Yep.
Meanwhile, let's set up a C-collar for the patient.
Okay.
Okay, Mr. Lee, is there any pain?
No, tummy is okay.
All right.
Pressing deeper, okay?
Okay,
So
meanwhile,
no
let's
pain.
get ready to do our secondary survey and log roll the patient.
Okay.
Once we
Is there
settle the
anything here?
C-collar.
No. So they've completed primary survey. Let's put on the collar and do the log roll and secondary survey.
Yep.
Okay, so it's very important for the team to make sure they put on a cervical collar. This will protect the cervical spine of the neck to prevent any injury and possible paralysis. So they're sliding the
Okay,
cervical
Mr.
collar.
Lee, try not to move your neck.
And you can see 2 of the students are immobilizing the neck while another student is putting on the cervical collar. Right? Centralize it. How's the patient, Caitlin? Is the patient still relatively stable?
Still relatively stable. Blood
Okay.
pressure is good.
Okay, let's.
Yes, let's have 3 people on that side and the rest of us here. Let's do a log roll.
Okay.
I'll check for spinal tenderness as well as do a DRE.
So the team is doing what is known as a log roll to examine the spine.
All right, on my count. Ready? 3, 2, 1, turn.
Okay, Mr. Lee, I'm going to press down your back. Please let me know if there's any pain.
No pain on my back, doctor.
Okay. Mr. Lee, I'm going to put my finger inside your backside. I need you to squeeze my finger, okay?
Normal anal tone.
Okay, and no
There's
saddle
no bleeding.
anesthesia.
No saddle
No
anesthesia.
bleeding. Okay.
The team is putting in what is known as a pelvic binder. This is stabilize pelvis that may be potentially fractured in a major accident or trauma. Okay.
Okay, 3,
Yep.
2, 1, turn.
You can see the team is moving the patient.
Okay, let's put the pelvic
a
binder in
unit.
place.
And they're putting the pelvic binder while they're stabilizing the pelvis. This will prevent or stabilize a potentially fractured pelvis.
Okay, putting the pelvic binder at the level of the greater trochanter.
Okay, good. Let's put the pelvic binder and let's do a quick secondary survey, head to toe, examine for
Okay,
any
meanwhile,
other
get
limb
ready
injuries
to examine the limbs
and do their
and get ready
ultrasound.
for a fast scan.
So as they're completing the injuries examination, so there's no pain over the upper limbs. Pelvic binder is in place, good. Let's complete the lower limb.
Okay, let's check the lower limbs and get ready for an ultrasound.
Yeah, there's no pain or deformity. Well, an ultrasound is being done. This is to look for any potential
Okay,
injuries
I'm noticing
to
that
the
the
abdomen.
saturation seems to be dropping.
Oxygen's at currently at max on NRM.
Okay, blood pressure is also dropping.
Okay, no free fluid in the Morrison's pouch.
Okay, there's no bleeding noted in the abdomen on the right side. How about the left side?
No free fluid in the left upper quadrant.
Okay, and suprapubic area.
No free fluid in the suprapubic area.
Okay, let's look at the heart.
Okay, I'm noting that the patient seems to be in shock. Let's activate the massive transfusion protocol.
Okay, good. The nurse is calling the blood bank and managed to get some blood.
Okay, let's check the 2 patient identifiers on the blood.
So let's make
Mr. Lee unmanned, S0567388B.
okay.
Blood type A is positive.
Okay, so
Okay.
make sure that the wrist matches the wrist tag.
Yep.
Does it match?
Yeah,
Okay.
accurate.
Okay, good. Very important. Make sure that they give the correct blood. Ultrasound is negative so far.
Yep, now we'll be doing the cardiac ultrasound.
Yep. Let's do the cardiac ultrasound. Okay. It's okay. Nope. Okay, on the other side.
It's over there. Mr. Lee, are you okay?
Can you bring?
Okay.
Okay, now I use the other
During
probe.
the cardiac ultrasound,
Okay,
I don't know any pericardial effusion. Contractility is normal.
okay.
On the next apical view, the contractility is
Use the other
normal,
probe, yeah.
No pericardial effusion. Okay.
Okay. Okay, fast scan is complete.
Okay, the ultrasound scan is normal.
Okay,
How's the patient?
patient's
Not
coming drowsy.
responding.
Okay, let's
Really?
Patient is
check the
now
pulse.
unresponsive.
No pulse.
Patient has no pulse.
Ventricular fibrillation.
Okay, rhythm shows VFib. Let's get ready to start CPR now. Let's
Patient
prepare
has,
adrenaline
gone
as
to
well as
cardiac arrest.
amiodarone and prepare to defibrillate. Ingin,
Patient has
can you
no
get ready to
pulse.
rotate for CPR later?
They're doing
Let's
CPR.
also bag the patient.
Patient has gone into abnormal rhythm. And what rhythm is it, Caitlin?
This is ventricular fibrillation.
Okay. So
So we're
let's get
placing
the
the
first shock.
defibrillator pads now.
Okay.
We'll be shocking at 150 joules unsynchronized.
Okay, good. So they're going to shock the patient now. Yep. It's a real defibrillator, everyone. So it's a real machine that is used on a real life patient.
2, 1, all clear?
Okay, so first shock given.
Okay, let's
Continues.
give IV adrenaline.
Okay, CPR is continued.
mg is 10 ml, so 1 in 10,000.
So they're giving drugs to restart the heart. CPR is ongoing. And
Okay, thank
they
you.
will do this for 2 minutes. 2 minutes up.
Okay, 2 minutes up. Let's check the rhythm again. still shows BFib. Let's get ready to defibrillate.
Okay, so the patient is still not responding. So you're going to shock again. Please proceed. Okay, so
shocking
safety
in
is very
3,
important.
2, 1, all clear.
Okay, second shock given.
Okay. No
Okay, not yet.
RST. I'm noting that the patient seems to be cyanosed centrally. Let's get ready to intubate the patient.
Okay, patient still not responding. So now they're going to put in a tube into the trachea and connect the patient to a ventilator to breathe for the patient as CPR is ongoing. So you can see Beth is using what is known as a video laryngoscope to see the trachea so that she can put the tube in to the trachea.
Okay, let's get ready to swap out for CPR soon.
And you can see on the video as the tube is going in.
Okay, visual confirmation of insertion of ECG.
Okay, good. Tube is in the right place.
Okay, let's do 5-point auscultation. Ingin, could you do that?
So the tube is in place, so they have to confirm that the tube is in the right
Self-inflated
area.
22 at
All right, let's make sure the color change is from purple to yellow.
Patient confirmed.
Okay.
Color change from purple to yellow.
All right, let's bag the patient.
CO2 detector, starting to bag.
All right.
Okay, tube is in the correct place.
All right, let's
and
check the
CPR is
rhythm again.
ongoing. And is the tube secured?
Yeah.
Okay, and 2 minutes up.
Okay, rhythm check. Still in VFib. Let's shock the patient.
Now you want to give another set of drugs in the meantime?
And let's also give IV
after the
adrenaline
shock,
as well as
okay.
IV amiodarone.
So shock first.
Charging. Shocking in 3, 2, 1, all clear.
Okay, so everyone has to stay clear before they give a shock. Okay, third shock given.
Okay, continue CPR. Let's give the medication.
What medicines are being given?
Giving adrenaline.
And imidazole. Okay, 150 milligrams.
Second.
Okay, CPR is ongoing.
Okay, I noticed that the patient is starting to respond. Let's take a look at the rhythm, check for the pulse.
Pulse present.
Okay, what time is it now? Let's check for what time ROSC occurred.
14:43.
14:43. Okay.
It looks like the patient has responded. There's some signs of life and the pulse is present, but the patient is still
Alright.
not breathing. Okay,
let's
let's
continue
continue to
to
reassess the patient.
Ventilate. Yeah.
In the meantime, do you want x-rays and all that to be done?
Yeah, I would like to order the trauma series. So let's do a chest X-ray as well as pelvic X-ray.
Okay, radiographer has been called and x-rays are being done. All right, so let's reassess the patient. So let's look at the vital signs. Are they stable now?
Okay, SpO2 seems to be dropping.
Yep.
Let's reassess the lung fields.
Okay.
Yeah, inspecting the lungs for any bilateral equal chest rise.
Okay, so right side maybe not moving as much as the left. Yep.
Okay, looking for any jugular venous.
No jugular venous distension.
Feeling for any tracheal deviation.
Trachea deviated to the left.
Okay.
Percussion.
Do percussion now.
So there's increased resonance on the right side.
Okay. Let's auscultate.
Okay, quickly auscultate. How's
Okay.
okay? Good. The ETT, the endotracheal tube is still working,
Yep, that's good.
but the saturation is dropping. So what's your assessment?
So at this point in time, I'm suspicious of a tension pneumothorax on the right side.
So what should be done?
I think we should do a needle decompression. So
Okay.
let's prepare for that. Needle compression in the second intercostal space, mid-clavicular line.
The team have detected a potential pneumothorax. That means the right lung has collapsed. There's air outside the lung in the pleural cavity compressing the lung. So they can do what is known as a needle decompression, or alternatively, you can do a finger thoracostomy.
Okay, meanwhile, let's prepare for the chest tube.
Okay, while they are doing the needle, you can see Nicholas putting in a needle to relieve the compression on the right lung. Okay, so usually you see some bubbling, right, as the tube goes in. Okay, so there's some bubbling seen, and let's quickly put in the
Yep,
chest
let's put the
tube.
chest tube in. Saturation's improving.
Okay, good. just read up. So they have relieved the tension pneumothorax on the right side to complete the management of the pneumothorax.
Saturation's improving.
Yep.
Ying is putting in a tube into the right side of the chest. This is to drain all the air from the pleural cavity. She's going to connect it to an underwater seal.
Okay, we're looking for oscillation as well as bubbling to make sure that the
Okay.
chest tube is inside too.
That's connected. And
Oscillating and bubbling confirmed.
All
okay,
right.
good.
We can remove the needle.
Yeah.
And then let's anchor the chest tube with a suture.
Okay, so they're going to put in a anchoring stitch and a purse string suture to stabilize the chest tube. Okay, while they're doing that, let's reassess the patient.
So the vitals seem to be improving. BP is 104/58. SpO2 is back to 100.
Okay.
Heart rate is 82, no longer tachycardic.
Okay, let's review all your investigations.
Yep,
And
so I'd like to take a look at the x-rays. So,
what do we see here? This was the x-ray before the patient deteriorated.
okay, so this confirms that there was indeed a right tension pneumothorax and mediastinal shift.
Okay,
The pelvic x-ray shows a widening of the symphysis pubis, fracture of the superior and inferior pubic rami, as well as widening of the sacroiliac joint. So this is a open book pelvic fracture.
okay, yep.
And this, I believe this is the x-ray that we took after the
Okay.
chest tube was placed
So
in.
we need an x-ray after the chest tube, yep.
Yep, and it's in situ, and this shows an ECG with sinus tachycardia.
Okay, good. What is the plan now in this position for this patient?
Okay, so for this patient, now I would like to start IV propofol as well as fentanyl for sedation. Like to call the trauma surgeon, prepare the patient for CT head, neck, chest, abdomen, and pelvis. And I think we should also update the patient's family.
Okay, good. Well done. So all that is being done and patient being ventilated, patient's connected to the ventilator. Trauma surgeons are here now and the patient is handed over to the trauma surgeon and patient is now brought to the CT scan room for further evaluation. That's the end of the scenario, everyone. Thank you very much. And we'll have a short debrief now. We'll just leave it as it is. Yeah. All right, everyone. How did that go?
I think it went all right. I
Okay.
think we managed to work together quite well as a team. If there were areas that we might have missed out on our own parts, we were there to pick up from each other and remind each other on what was next.
Okay.
Yeah.
It was a complicated scenario, all right? Patient with severe injuries from the road traffic accident. So it's good that you picked up the fact that he had a pneumothorax on the right side, all right, which is a potentially life-threatening injury. You managed to intubate the patient, you did CPR, you did defibrillation, put in the pelvic binder, and you activated the massive transfusion protocol, giving the patient massive amounts of blood in a patient who's potentially bleeding massively from trauma, all right? So these are all the important points when you manage a patient with major trauma, all right? So the aim is actually to go through the primary and secondary survey of advanced trauma life support. Okay, great. So what are the things that you have learned from this, going through this simulated session? So some of the things that you have learned yourself.
I think this was a very good learning opportunity for me, especially in terms of like practicing our teamwork and communication, which I believe both are very important in medicine.
Yeah. Okay, so exactly, it can be a very chaotic situation, right? When a patient is deteriorating right in front of your very eyes. So teamwork is very important. What else have you learned?
I think it gave us an opportunity to try procedures that we wouldn't usually get a lot of chance to do,
Yep.
especially in the wards, where we may not have access to such dire and life-threatening.
Absolutely. All right. So here you can actually practice on the mannequin without any harm. All right. Yep. Absolutely. All right. What else have you all learned from this?
I think the safe environment to practice,
Yep.
especially since some of these things, it might be our first time doing these procedures or managing such a patient. So this simulation is a good place for students to learn this stuff.
Absolutely. So safety is very important, right? So this was a real defibrillator that they used. So doing procedures safely in a chaotic situation is very, very, very important to make sure that everyone is safe, right? What else did you all learn?
I think it also gave us a chance to practice things more in the context of like being our own leaders and things like that. Because when we're in the wards, usually we're the most junior, there are senior consultants there to help us out. So this is a good chance for us to actually try leading the trauma team, dictating what needs to be done and making sure that we hit everything that we
All right.
need to do.
Absolutely. So it's giving you an opportunity, right, to take up leadership roles, because one day you're going to be leaders, all right? So, and it's all right to make mistakes here, all right? Anything else that you have learned?
I think this is I agree with my colleagues that this is a very safe environment for us to practice procedures that we can use in the future. And I think it's important to practice on things like a mannequin first before we do it on a real patient. Yeah, this for patient safety as well.
Yeah, so it was a real defibrillator, everyone. So it's a real machine that's used on real life patients, so there's safety involved. Yeah. So you got to practice on a mannequin before you actually do it on a real life patient. All right. Caris, what else have you learned from it?
Oh, yeah, I think this experience is especially valuable during this COVID-19 times where it's quite difficult for everyone. Also, we have limited exposure out in the hospitals and the wards. So this is a really good opportunity for us to put our knowledge to the test.
Yeah, absolutely. All right. So putting what you've learned in the classroom, putting it into real life practice in a simulated and safe environment. All right. So everyone, we use simulation as one of the tools to train our medical students in difficult sort of scenarios that they may not encounter on a daily basis. The aim is to produce safe, competent, compassionate doctors in future. These are fourth-year medical students. They've got one more year to go, after which they will graduate and they will be out there treating everyone else. All right. So simulation is an important tool that we use in the school to train our medical students. All right. So thank you everyone for your time, and we wish you a pleasant day.